So first, let's talk about pain assessment in the medically ill. You may be aware that one of the most important conceptual changes that has happened in the area of pain management has been the recognition that pain can be considered an illness in its own right. Pain is not a sensation, pain is not a symptom, but when pain becomes chronic, it can be considered an illness in its own right because it's associated with impairments in a range of activities and functions that the patient is trying to do. Chronic pain has been associated with impaired physical functioning, impaired psychosocial and role functioning, mood disturbance, fatigue and sleep disturbance, overall poor quality of life, and high health utilization. Now, importantly, in patients who have a serious or life-threatening illness, who also have chronic pain, pain, which can be viewed as an illness in its own right, also relates to a broader construct. And that broader construct has been called suffering or total pain. Now, interestingly, for those of you who also deal with populations of patients with chronic pain unrelated to medical illness, pain as illness in that population is also associated with a larger construct, and that construct is called disability. So when we're talking about patients with advanced cancer or advanced heart failure, we don't usually use the term disability. We use the term suffering to think about the larger construct to which pain contributes. So one can consider pain as a multidimensional phenomenon that can itself impair many elements of quality of life, but relate as well to this broader construct of suffering. Suffering may have its own contributing factors that may be related to psychiatric, psychosocial consequences of the pain or comorbidities. It may be related to physical or medical comorbidities or a variety of other things such as distress in the family. Social support, coping, and adaptation, the resilience of the patient, can be viewed as moderating factors that might influence the extent to which pain influences this broader construct of suffering. And this I'm sure you've seen in your own clinical practice. Speaking anecdotally, some patients have moderate pain but suffer greatly. Some patients have very severe pain, but they don't appear to be suffering. Some patients have severe pain and function quite well. Some patients have moderate pain and completely become incapable of functioning. And this kind of complexity suggests that the assessment of chronic pain in a population with serious medical illness has to go beyond even the dimensions of pain, dimensions like severity and the temporal relationships, what makes it worse, what makes it better. The assessment of pain in the medically ill has to look at the broader construct of suffering and ask the question, to what extent is pain contributing to this, and what are the other factors that are contributing to suffering? So how do you assess pain? Well, as I mentioned before, there are a variety of factors that all of you know how to assess, things like intensity or the temporal relationships, the quality. But what I would suggest to you is that there's an objective to that assessment, and the objective is to characterize the patient's pain in terms of three broad phenomena: the syndrome, the etiology, and the pathophysiology. This is actually a very important, for me anyway, a very important conceptual leap, because the tendency is to evaluate pain in terms of its intensity and maybe in terms of its consequences, and then just to treat it with analgesics. But if you begin to think about the importance of assessing pain in terms of its etiology, its syndrome, and its pathophysiology, then the door opens widely for a variety of other considerations. Are there disease-modifying therapies that can reduce the impact of the etiology? For example, radiotherapy to a bony lesion. That's an obvious one, but there are many that are less obvious. Is there a syndrome attached to the pain that helps you prognosticate or to select a specific type of therapy? Is there a pathophysiology, like neuropathic pain, that you would attach to that pain complaint, and that suggests specific types of therapies that wouldn't be suggested otherwise? So this is the important construct for me, and it represents a change in the way pain assessment has been taught. In the medically ill, if you have a patient with chronic pain, the assessment should lead to an understanding of the syndrome, if it can be identified, the etiology, and the pathophysiology, and then the patient with pain should be characterized in terms of the physical and psychosocial consequences the comorbidities, and related concerns. Now, the diagnosis of the syndrome and the etiology requires an understanding of the underlying disease and its relationship to pain, and that in turn may require laboratory imaging tests or referral to specialists for evaluation. Many years ago, my colleagues and I at Sloan Kettering did a survey, and the point of the survey was to ask a very simple question. How often did cancer patients referred for pain end up having a different diagnosis or an opportunity for primary anti-neoplastic therapy as a result of the pain consult? So we were pain consultants. We got called in because the patient had pain that wasn't well controlled. And we asked the question, if we do our routine assessment, focus not just on characterizing the pain, but also the syndrome, the etiology, the pathophysiology, the consequences, the comorbidities. If we did our normal work, how often did we hand to the oncologist a new diagnosis or an opportunity for chemotherapy or radiotherapy that didn't exist before? The answer was 40% of the time. So this is a very important point, whether you're talking about the cancer population or the population with advanced heart disease or liver disease or kidney disease. The diagnosis of the pain, syndrome, and etiology and the inference made about the pathophysiology requires that you know about the disease itself. It's never appropriate, in my view, to walk away from a patient with the primary goal of treating the pain, ignorant about the status of the underlying disease and its comorbidities. That's always a bad decision. The pathophysiology, you should realize, is an inference. Because you'll evaluate a patient, I'll evaluate a patient, we really don't know what the pathophysiology is, and it's far more complex than we could explain anyway. But what we have done, what the scientific community has done, is create these large buckets, these constructs that imply a set of pathophysiologies. And the main buckets that we label in populations with serious medical illness are nociceptive, neuropathic, psychogenic, and mixed. Nociceptive pain is pain that's inferred to be related to ongoing tissue injury. Inflammation is often very prominent. The implication is if you take away the source, the patient feels better. Neuropathic pain is pain inferred to be related to injury to the nervous system. Sometimes, if you take away the source, the patient gets better, like if a nerve is being entrapped. But sometimes, the pain mechanism has moved upstream into the central nervous system, and you can't take away the source. Sometimes the pain occurs because of a lesion in the nervous system, like a stroke or a tumor in the brain or spinal cord injury. So neuropathic pain, the inference that a patient has neuropathic pain is based on the clinical characteristics. It's just an inference, but it's important because, as I'll talk about later, it suggests different kinds of therapies. Psychogenic pain is pain inferred to be primarily related to a somatoform disorder, it's a psychiatric diagnosis, and that is much less common. That's probably even, you could say, is rare in populations with serious medical illness. However, psychological factors driving the pain complaint, as I mentioned before, is not rare. Pain consequences include medical, psychiatric, psychosocial, and spiritual consequences and consequences on the functioning of the patient. And the comorbidities and related concerns refer to all the domains of palliative care. So when you get called in to see a patient with chronic pain, in the context of serious medical illness, the assessment is actually a very complex undertaking. You need to characterize the pain. You need to try to understand the pain in terms of syndrome, etiology, and pathophysiology, and consequences and comorbidities. And you need to try to understand the other factors driving suffering. And as I try to teach our fellows every year, part of the complexity is that routine documentation of that kind of assessment is not typically what you see in medical records. And so one of the big problems we have is that we don't even know how to take that process and write it down in a way that our colleagues on the team or our colleagues who are called for consultants know what our thinking is. And that's a challenge I'll lay to you. I have my own type of documentation. It's very idiosyncratic, and I get away with it because I'm old. But you need to think about how do you want to document this complexity. When you say patient has pain, 8 out of 10, we'll do this. That documentation says absolutely nothing. Now that documentation may be okay after there's another note that says this patient has multifocal bone pain related to metastatic disease. Patient will be getting a bisphosphonate and chemotherapy for 2 more cycles, but has had progressive decline in functioning. Patient has a high level of distress related to that and to a sleep disorder. Pain is very severe when the patient moves. That may give you enough to then write an assessment that says that the etiology is metastatic disease, the syndrome is multifocal bone pain, the pathophysiology is nociceptive, and the plan of care will be to do the following. Then the next note, you could say pain is still an 8 out of 10, we'll increase the opioid, or we'll give the patient an NSAID. Okay? So this is the more complex rendering of that set of concepts, that set of constructs that I was describing. Pain itself can be described in terms of mechanisms or pathophysiology, nociceptive, neuropathic, psychological. It can also be described in terms of etiology or characterized globally as a syndrome. Pain relates to a broader construct of suffering. Pain has pain consequences. That impact of pain can contribute to suffering, but there are many other factors that contribute to suffering, including psychiatric, physical, psychosocial, spiritual comorbidities and related concerns. This schematic is what you want to wrap your arms around in order to do a comprehensive and nuanced pain assessment, leading to a plan of care that addresses not just comfort, but suffering. And if you do that, you'll end up with an understanding of the pain diagnosis and consequences in the first circle, the top circle, and you'll end up with an understanding of other factors related to the palliative care needs of the patient. That's the lower circle. And then you may be able to offer primary treatment for the etiology of the pain, primary treatment for the etiology of comorbidities, symptomatic therapies for the pain, and symptomatic therapies for the consequences and comorbidities of the pain. And that, to me, is a part of the plan of care related to symptom distress and other factors. Now, if you're talking specifically about symptomatic treatment of pain, there is an enlarging menu of strategies that continues to grow year in and year out with new entities coming on the market that are pharmacological or related to new devices or new techniques. The way that I like to conceptualize the many therapies available for pain is depicted on this slide. Pharmacotherapy includes non-opioid drugs, the so-called adjuvant analgesics and opioids. Psychological approaches include education of the patient and family, cognitive behavioral strategies, and other types of psychological approaches. Interventional strategies include injection therapies, nerve blocks, and implant therapies. Rehabilitative therapies include PT and OT and modalities like TENS and use of cold and use of heat, as well as orthotics. Integrative therapies include acupuncture, chiropractic, music therapy, and others. Neuromodulatory therapies include TENS, transcranial approaches, these are non-invasive, and then the invasive types of neuromodulation like spinal cord stimulation, and lifestyle changes. So as you think back to the last 100 patients with pain who you treated or collaborated in a team approach to treatment, the first question I would ask is, how often did the plan of care consider entities in these various categories? Because if the answer to that is, well, we never do anything but give drugs, then I would say that I'm glad you're here in this seminar on advanced pain management. Drugs are very important. I'm personally in favor of drugs. I'm a strong believer and promoter of drugs. But it's very important, I think, when one thinks about the construct of suffering as this phenomenon to which pain contributes, and you think about pain as a multidimensional phenomenon in its own right, an illness in its own right, that you broaden your thinking and realize that the way to effectively manage pain and reduce suffering may or may not emphasize pharmacotherapy. Now, in the medically ill population, pharmacotherapy tends to be the #1 approach, and that's what I'm going to focus on today. For two reasons. It's the #1 approach, and it's the approach that I know something about. So these are the strategies that are used to treat pain and serious illness: pharmacotherapy, psychological approaches that tend to be more psychoeducational, interventional strategies, which I know are underused in many places around the country, rehabilitative therapies, integrative therapies. If you think about patients with chronic low back pain, most pain specialists will think about a strategy that involves a different type of menu. Look at the difference here. So our menu, our primary strategies used for chronic pain related to medical illness looks like this, with an emphasis on pharmacotherapy, complementary approaches, and interventions secondarily. For chronic low back pain patients, we also use pharmacotherapy but de-emphasize opioids, do different types of psychological interventions, emphasize interventional strategies and neuromodulation, and then also do rehabilitative and integrative approaches. So how do you develop the plan of care if you go through that assessment? Pain due to active cancer and other serious or life-threatening illnesses does evoke an international consensus about the strategy. This is really terrific for us because there's no consensus at all about how to treat the patient with low back pain. In fact, there's no consensus about what is low back pain. In fact, some people don't think there is low back pain. So I think there is low back pain, but I realize it's a very complex set of diseases and illnesses, and that complicates a plan of care. But the plan of care in patients who have serious or life-threatening illnesses has generated an international consensus that's indicated here on the slide. Opioid therapy is the first line if the pain is moderate or severe. NSAIDs and adjuvant analgesics are used commonly and adjunctively, and both non-invasive and invasive non-pharmacological treatments are considered adjunct approaches. So pharmacotherapy is the mainstay approach. And as I mentioned before, pharmacotherapy can be looked at as falling into three broad categories of drugs: opioid analgesics, non-opioid analgesics, and the so-called adjuvant or non-traditional analgesics.